Hi, everybody. My name is Natalia Miller, and I am a pediatrician, and I am the medical director of the Pediatric SANE program through the Children's Advocacy Center of Jackson County in Medford. And I'm going to let Cherith introduce herself.
My name is Cherith Young. I am the SANE coordinator for adult and pediatrics here in Southern Oregon.
And we're going to talk to you today about a pediatric SANE model within a regional children's advocacy center. Our program started down here in 2018, and we're going to talk a lot about how we went about starting that program, how we continue to manage the program, and some of the details involving it, in addition to just some basic background about the Children's Advocacy Center model and child abuse and child sexual abuse. So we have no financial relationships or endorsements to disclose. And we do not support any particular product discussed in this presentation. So I think it's helpful just to get oriented, to make sure we all understand what child sexual abuse is. And I know all of you listening to this are very familiar with much of this. So, but I wanted to just start out to make sure we're framing this with the same definitions. So, child sexual abuse, we know, is preventable, and it's an adverse childhood experience. And it is a very large public health problem. And it refers to the involvement of a child, a person less than 18 years old, in sexual activity that violates the laws or social taboos of the society which that person is a part of. And the person does not fully comprehend, cannot give consent to, or is unable to give informed consent to, or is not developmentally prepared to give consent to. And the problem is significant. So there are various estimates, but the CDC estimates that about 1 in 4 girls and 1 in 13 boys experience child sexual abuse at some point in childhood. And we know that most child sexual abuse is perpetrated by somebody well known to the child. And the total lifetime burden in 2015, at least, was estimated to be at around $9.3 billion. And we know that that is an underestimate. So I think before we go any further, I wanted to make sure that everyone understood the Children's Advocacy Center model, because this talk is about how to integrate a pediatric SANE program within a very established evidence-based model for child abuse evaluation. And so I have just over a minute-long video that I thought we would watch, and this is put out by the national accrediting body for CACs. So.
A Children's Advocacy Center, or CAC, provides support to victims of child abuse. Without a CAC, an abused child may have to tell their story over and over again in settings that may be scary or where kids may think that they're in trouble. Then, families have to search around for the services their children need, all on their own. But in a CAC, a child tells their story to a trained interviewer who makes the process gentle on the child and finds the facts which are crucial to the child's case. Then, a community of professionals in medicine, law enforcement and child protective services, prosecution, victim advocacy, and other heroes work through the CAC to decide the best way to help the child. And CACs provide science-backed mental health care that heals kids from trauma and helps them reclaim their futures. This community of caring professionals rallies around the child so children have everything they need, all in one place, at the CAC. To find your local CAC or to sign up for updates, visit nationalchildren'salliance.org.
When a report is made of child abuse, a child is typically brought to a children's advocacy center, or sometimes presents initially to the emergency department. An investigation begins, and this very coordinated approach starts. And like the video said, it involves a forensic interview by very specialized individuals with training in that. It may or may not involve involve forensic evidence collection with photography, and then medical treatment and examination. So following all of that, the CAC coordinates a multidisciplinary case review involving all of those different people that play a role in the evaluation of that child's case and subsequent treatment and recovery. So the CACs facilitate services and coordination. So for children that present to the hospital, initially to the emergency department, the challenge is how to get those kids sort of into the CAC model following that acute evaluation in the hospital. And that's really important because after the initial examination in the hospital, if that's the case, there may or may not be a need for a follow-up exam. We want that child to be offered therapy. There is going to be need for some advocacy with the family, and then the forensic interview, and then ongoing education and prevention opportunities for the family. So the National Children's Alliance is the accrediting body for children's advocacy centers. And this is really important because every program that is a part of the CAC and every service that is delivered, there are very, very strict standards around how things are going to happen, and they're evidence-based, and the accreditation cycles every 5 years. So when we were thinking about starting a pediatric SANE program, we had to look at this, and we had to look at the NCA standards, because the CAC program, our vision was that, or the PSANE program, our vision was that it would be embedded into the CAC model. And so the NCA standards were really important. And there are over 700 accredited CACs in the United States. So what is acute sexual assault? So some time ago, this is not the most current definition, but there was a joint position statement put out by child abuse medical providers in Oregon and the Oregon Network of Child Abuse Intervention Centers and the Sexual Assault Task Force. And they defined it as acute anal genital injury or bleeding thought or believed to be secondary to sexual abuse or sexual abuse that has occurred generally within 84 hours preceding an examination, which necessitates documentation and may necessitate collection of forensic evidence. Now, the timeline of evidence collection has evolved since that time, but I think that gives us a framework for what we're actually talking about. And this is the types of cases that present to the emergency department for an acute evaluation. So our challenge was to develop a program that functions within the CAC model that adheres to all of the NCA standards in order to maintain accreditation of the CAC of Jackson County. So as we were thinking about this kind of early in 2016, 2017 was when we were laying the groundwork for this program. There were some statements of condition that I think are facts that we had to look at really closely. And so what did we know? So we know that children present 24/7 with acute sexual abuse to both emergency departments and primary care providers. And we also know that most community CACs, especially those in more rural areas, do not have capacity to provide 24/7 coverage. We also know that accredited CACs facilitate a multidisciplinary approach to child maltreatment, and it is the standard of care for child abuse. So utilizing a really wonderful multidisciplinary system that's already in place, it seemed to make sense to integrate a pediatric SANE program into the CAC model. And finally, acute sexual abuse cases, child sexual abuse cases should be handled in the same manner and quality, no matter where they present, no matter what time of day they present. So where did we start? So we started by looking at the incidence of child sexual abuse in our community. And it's fairly high. So the last time I had looked at the numbers, and they haven't changed much, Jackson County was about 9th of the 34 of 36 counties in Oregon in incidence of child abuse per capita. And there's also, when you look at these specific incidents broken down by type of abuse, there's very high incidence of child sexual abuse here. And then we looked at what was the current coverage and response algorithm for the emergency department patients that presented to the emergency department with acute sexual abuse concerns. So what we found was that it was all over the place. There really wasn't a standard or an algorithm that was followed consistently. We know just in estimating that the financial costs and burdens of the community are high. We know that's true nationally and that our community is no exception. And we also looked at what it really takes for really non-specialized individuals to do child sexual abuse consultations in the emergency department, say with general providers, physicians or mid-level providers, that child abuse cases often require significant time beyond the initial encounter. There is communication that happens well after the case. There's court proceedings that may happen, and it really does not only in real time, but also after the examination, strain the PCP offices and the ER providers. So, and we know, and I think this is undisputed, that a specialized evaluation for child sexual abuse and expert review of findings is the standard of care, and it is imperative to the accurate diagnosis and treatment of sexual abuse. And acute sexual abuse is no exception. So our problem and proposed solution. So there's this gap in coverage, and our solution was to partner with the medical community to initiate and sustain a pediatric SANE program, and that is really embedded in and integrated into the Children's Advocacy Center model for children under the age of 15 presenting with acute sexual abuse complaints. And so our key stakeholders, so this was one of the very first steps, is determining who needed to be at the table to have these discussions about funding, about how the program would work, who would oversee the program, who would provide quality control of the program and coordinate logistics. So the first stakeholder was the Children's Advocacy Center Administration and Board. Our executive director has been a real champion of the Pediatric SANE program and has enlisted the board support as well of the CAC. And so they were behind this from the beginning because they recognized the severe need that our community had to have that 24/7 response available to kids. Another stakeholder was our local hospital system administration. And this is like somebody in the role of a vice president of medical affairs, a CEO of medical affairs, somebody who has the decision-making ability, but also who understands the clinical and administrative aspects of a program like this and has ties to the foundation and funding sources as well. We also had a direct tie to a hospital foundation representative, which was extremely helpful, and I'll get to that. And then clinicians. We had a few clinicians sitting on our panel, and that was a primary care provider, a pediatrician, and then a couple different ER providers, medical directors of our ERs. And these were people that very clearly understood the need. They've managed these cases in the emergency department and understand how a pediatric SANE program would fit into the patient flow. And then lastly, the district attorney's office was a part of these early discussions as well. So the National Children's Alliance, which again is the accrediting body for CACs, they put out as part of accreditation, but they put out standards for credentialing and for training. So for pediatric sexual assault nurse examiners, the certification that's required is a 40-hour SANE P training, which is competency-based and a clinical preceptorship. And they don't require IAFN certification, but providers who have completed SANE training and preceptorship, they state may choose to apply for certification within the IAFN. So we started there when we looked at how we were going to start training our nurses. So when we were putting together a proposal to take back to this group of stakeholders, these were the things we were looking at. And this is what we came up with, and this is what we can use today. So we have all of our nurses participate in the Midwest Regional Children's Advocacy Center 40-hour PSANE training, which is IAFN endorsed. They are required to do 4 clinical preceptorship exams with increasing autonomy as they progress through that process. And then an additional 10 hours of very specific training with the medical director. And that involves didactic training. It involves sort of on-site training in the emergency department, a cart tour, just reviewing all of the workflow, the materials, the equipment that is used and such. And so as we were developing the program standards, we were taking this back to the key stakeholders. And fortunately, we had a very committed group of stakeholders that really saw this through, and they showed up and they participated and they were really invested in this process. And after about a year and a half of discussions, the chief medical officer of one of our hospitals presented this proposal, and that included the quality measures, the annual projected budget, the program outline, presented it to the hospital foundation, and they came back with an initial grant for 3 years of full funding. So that was just amazing news when that happened, because that allowed us then to turn all of these ideas into action and start getting our nurses hired, start really solidifying a lot of the plans that we had been dreaming about and had put on paper. But then when we had funding, then we could really move forward. So what do we have now? So our program started in October of 2018. We have the core group that started with us is really the same. So we have about 4 people that have not transitioned out of our program. So they've been just very solid and consistent. And then we have about 1 or 2 nurses that have turned over. So we have between 5 or 6 nurses at all times, and they're all either pediatric nurses or emergency department nurses. We have a program coordinator, which is Cherith. And then we have myself, the medical director, and we cover 2 hospitals, and we have a backup nurse who responds for photography help when needed. So when our nurse is called in, and I'll go through a lot more detail about all of this, but when our nurse is called in, we have arranged for a second nurse to be able to respond if available for a maximum of 2 hours, just for technical help with photographs if needed. And then all of our nurses are working toward getting IAFN certification, and we complete about 1 to 2 exams per month. So our training, this is just a list of what we try to cover, what we think is important, and this is just kind of, I know the foundation is laid with the 40-hour training that is completed through MRCAC or IAFN, but child sexual abuse basics and the Children's Advocacy Center model are really important for our nurses to understand. The body and anal genital exam and the history collection in a trauma-informed manner, we cover that. We make sure our nurses are really familiar with normal anatomy across child development, so from infancy up into adolescence. And we look at pathology, and we look at mimickers of abuse as well. We look at STD testing and treatment. We make sure our nurses are very skilled at understanding the exam logistics and how to navigate through the exam and through the paperwork and the flow of the exam. We give extensive training in photography, and then of course collection of the safe kit and chain of custody protocols, documentation, and then court. So for ongoing training and peer review, we have requirements for our nurses, so that all trainings offered, that our nurses participate in 75% of the trainings that are offered. And we offer the monthly peer review, again, through Midwest Regional Children's Advocacy Center, and that's a PSANE peer review once a month, and everybody logs in from their respective sites, and we present a case also once or twice a year, and that's just extremely valuable. So in addition to that, we do a quarterly regional peer review that is local to Jackson County, which is a regional Children's Advocacy Center. And that's a 2-hour program where we do peer-to-peer education, where our nurses will present topics or cases or maybe journal articles, and we take some time to review. We also do mock exams in that time as well, and just basically come together to review new guidelines, to discuss cases, and we have a policy in place that if our nurses go 6 months with no exam, they are required to do either a mock exam at the CAC or at the simulation lab at the hospital, and until they can re-enter the call pool. And that's just a quality measure, a quality improvement protocol that we have to ensure competency, because as we know, acute child sexual abuse is really, it's not that prevalent, and so much less prevalent than what is seen in adults. When we're seeing 1 to 2 exams per month, you might go a few months or more without an examination, but your competency and your skill levels still need to be, you know, very high in order to do that exam confidently when you're called in to do it. And then we also provide some legal trainings where we have done a mock court session with our local district attorney's office and defense counsel, and we'll do CV prep sessions, always making sure that we're keeping our CVs up to date. And we do annual feedback sessions with our program leadership. So we ask our nurses to sit down and give feedback every year as to how the program is functioning, areas that we could target for improvement. And then lastly, expert review of exam documentation. So every exam that is done, the medical director will review the exam in its entirety, from the medical record to the photographs, and then write an addendum to that note, and then circle back around with the nurse to give feedback about any or all aspects of the exam, which our nurses have been really appreciative of and open to. And that just creates a really transparent culture where we are just always trying to do what we can to improve, and everybody just has a stance of, you know, trying to provide the best quality of care possible. There's some training aids that we use, and one is this pelvic model, which is very helpful when we're practicing evidence collection and exam techniques with labial separation, labial traction, you know, and looking at anatomy. It's very, very helpful. So we use this pretty routinely. In addition, the drying rack, I just wanted to point this out, that I personally think that one of the biggest barriers in collecting forensic evidence is ensuring that the swabs don't get out of order and that they are labeled appropriately. So when they're placed in the drying rack, that can be a barrier if you don't have them labeled. So I just wanted to show you what we do. You can see outer vaginal, inner vaginal, cervical, rectal, perianal, penis, body swabs, oral standards, oral sodomy, and whatnot. So you just have to make sure you know of the body swabs, which locations those are from, and which areas they correspond to. This is our simulation lab that the hospital lets us use. This is obviously, our program is very supported by the hospital, which has been extremely critical, and the resources that the hospital has then are opened up to us for training purposes. So the simulation lab, this was an amazing learning experience where the coordinator of the lab you know, created bruises and injuries on this model, and we were able to do a full forensic exam with photography, documentation. We had a scenario, and it was real time, and the nurses worked together. And it wasn't, I think it was 2 days after this examination, or this mock exam, that one of the nurses in the picture here had almost the same exact scenario in the ER. And she was very thankful that we had basically 2 days prior just gone through the entire thing. So very helpful if you have something like this to continue to, you know, enhance and develop your skills. And then mock court. This is something we recently did. I mentioned it earlier, but this involved the district attorney's office, the defense. We had a local defense attorney participate, and that's me giving mock testimony of a scenario that we, a hypothetical scenario that we created. And one of our local judges donated the courtroom for the afternoon. So this was just valuable. Every nurse was able to get up, get on the stand, practice the qualification process, and then practice testifying and discussing, why it's normal to be normal, what the PSANE program is, what was done, what the exam process is, and to articulate that in the setting of a courtroom, I think is really just a really valuable learning experience, and can't be replicated by just reading about court or thinking about court. So I think our nurses really appreciated this experience of being able to work through some of the unknowns of the court testimony process without actually having to go to court and be on the record. So if you have an opportunity to do something like this, I think it's very helpful, whether you're pediatric, adolescent, or adult SANE nurse. And so I want to just briefly touch on the task force endorsement that we got. So we all know that there is a lack of statewide pediatric certification, and this can be a barrier, especially in court, when you're asked, how are you certified, or what is your certification? Because none of our nurses at this moment have IAFN certification. So while we call them pediatric SANE nurses, that's really just so that people understand what their role is, and it's not confusing as to what they're doing in the hospital and what their role is in being called in to see that patient for a forensic examination. But we make it very clear that there's no IAFN certification behind their name, so we don't want to pretend that that's the case, because it's not. So when we're asked about that in court, we wanted to be able to have some some endorsement from our task force, and we approached the task force and had them review the components of the program, the training requirements, the ongoing requirements, the quality improvement initiatives, just really all aspects of it. And we were able to get an endorsement from the program. And I think that has been really important. It's been important for foundation reporting to the hospital, who is our funder, and also for the court qualification process. And as I said, our nurses are working toward IAFN, but as you know, that is not something that happens overnight. And so we didn't want to wait for that process without, having nurses have to have experience before they can even do that. And most of our nurses actually are not dual certified in adult and pediatrics. We just have a couple that are. So I just wanted to go over the exam process a little bit, just to give you an idea of how we've set this up to flow. So what is the pediatric forensic evaluation? So it's an adjunctive focused evaluation by a forensic nurse, and it includes a history, a physical, evidence collection, documentation of injuries and or infections resulting from sexual abuse, so that an objective forensic assessment of the child's anogenital findings can be made. And what it is not is a substitute for a qualified medical evaluation by a qualified provider. So when kids come into the emergency room, the pediatric SANE team is in the role of a consultant. They are not the primary team seeing the patient. The child comes to the emergency room like any other pediatric patient would, and goes through triage, gets evaluated by a provider, states their chief complaint, to which the provider asks questions and performs a history and physical as usual. And if it is determined that there is a concern for acute child sexual abuse, or a mandatory report obviously needs to be made by the provider. And then after that, if needed, the provider calls the pediatric SANE program and requests a consultation. So why do kids present to the emergency department for sexual abuse concerns? So typically, it's because there was a specific disclosure or witnessed acute sexual abuse incident. There can also be symptoms, and in children, we actually see this quite a bit. They might be specific or non-specific to the anogenital area, but symptoms that a caregiver, especially with given the unclear history, can't really interpret. or worries. And so they present to the emergency room for further evaluation. Another reason is misunderstood anatomy. We get those calls a lot where a provider might, or a parent might bring a child in because they say something just doesn't look right down there. There are cases where videos or other images are found of children and they're brought to the emergency department for almost a wellness examination in the context of child sexual abuse. And there also might be concerns of exposures to high-risk offenders or specific behaviors or non-specific behaviors or change in behavior patterns. And in children, you get all kinds of things, all of this and everything in between. And it's not always, exactly clear right when they come to the emergency department, but this is some of the reasons that they present. Okay, so how are kids triaged in the emergency department? So we've provided our local emergency departments with this algorithm, and I think there are various forms of this that people have put out on the state level and locally, but this is what we use. And we also train the providers in the emergency departments on just basics in child sexual abuse and how to most effectively utilize the Pediatric SANE program. And I think this is helpful because in a busy emergency department with providers that might not have a comprehensive background in child sexual abuse, which most don't, any guidance that they can be given is usually received very happily. So for the timing of medical evaluations, so the National Children's Alliance, as well as what are known as the Adams Guidelines. This is guidelines for the medical assessment and care of children who have been sexually abused. They put out indications for emergency evaluations, urgent, non-urgent, and follow-up. So for emergency evaluations, if there are medical, psychological, or safety concerns, such as acute bleeding or pain, suicidal ideation or suspected trafficking, or an alleged assault may have occurred within the previous 72 hours. Now, the state of Oregon, as it indicates here, may have another interval. And so in an adolescent and adult, that's extended to 120 hours. And in a prepubertal child, that's 24 hours with some exceptions. So obviously, the need for evidence, need for emergency contraception, or the need for PEP for STIs, including HIV. So for prepubertal children, the literature supports that urgent evidence collection is done if the child presents within 24 hours or under 24 hours of the alleged incident. And in general, we collect evidence ASAP, but we don't rule out evidence collection if it's greater than 24 hours in a prepubertal child. So there isn't hard and fast rules where every time we do the same, we do the same thing. It really depends on the specifics of the case, because sometimes the history is not exactly clear, but there's compelling evidence in some other area as to why we should collect evidence at 50 hours in a child. And there have been a couple different papers that have been, this is back a few years now, but that have demonstrated cases where prepubertal children, evidence has been recovered well beyond 24 hours. So it really depends on the specifics of the case. But in general, we know that urgent evidence collection if it's within 24 hours. Another thing to remember is that we expect normal examinations in children. So whether the anogenital exam is normal or abnormal does not determine whether evidence should be collected or not. So if a child has a normal examination, that does not mean we shouldn't collect evidence, which I'm sure you know that. And clothing and bedding are the highest yield items in prepubertal children. So we always have to be reminding those investigators that obtaining the child's underwear, clothing, sheets, linens, anything that was in contact with their body, or that has been identified to be a potential carrier of evidence should be collected and processed. And in adolescent and pubertal children, sooner the better, of course, but up to 24 hours following the assault, because we know that sperm can live that long in the vaginal area. So we talked about training our nurses on taking a medical history, a focused medical history in the context of child sexual abuse, and just to review kind of how that looks in pediatrics. So obviously the history of the event, the history of the contact, the body sites that were involved, any questions that we're asking children are to guide our examination. They are not so that we can use that information to investigate in any way. We are using the information to figure out how we're going to best manage the forensic evaluation, where we are going to collect swabs. It's important to know what touched what where so that we know what to collect and what swabs to do and where to do them. We often ask about what happened since the event, how's the family feeling, any behavioral responses from the child, and then what has already occurred. Has there been an interview? Has there been any mental health screening? Because we do a brief mental health screening as well as part of our evaluation. Past medical history that's pertinent, obviously, is developmental history, sexual development, menstrual history in girls, prior abuse history, and vaccination history, especially HPV and hepatitis B, significant health problems in families. We're looking at the social history because often DHS is involved in cases when there's threats in the home and children aren't safe. So having some idea of whether there's been an exposure to violence in the home, substance abuse currently or in the past, does the child feel safe in the home, and has there been child welfare involvement? And then, of course, a brief review of systems to just do a screening, and if anything is brought up in that, we make sure that that information is passed to the child's medical provider in the emergency department so that those medical issues can be dealt with appropriately. So as we mentioned before, after the examination is done, all exams and photos are reviewed by the medical director, and an addendum, including which would include the assessment of those findings with the interpretation of the genital photo and documentation, is included in the medical record. And feedback is given to the nurse after each examination, and the nurse and medical director are invited to participate in the MDT multidisciplinary team staffing of the case, which happens in every case of child abuse. It goes through a multidisciplinary review process. And in Jackson County, that's on a standing weekly meeting. And when that case has come up on the agenda to present, both the nurse and the medical director are invited to share the acute evaluation piece with the rest of the community partners so that everybody has full understanding of the medical information.
Natalia, I just wanted to speak to that. I think this process is extremely important because for a SANE nurse doing an exam every 3 to 4 months, I feel like I'm not the expert in genital trauma and injuries. So having a physician review my chart, interpret the genital photo and document the photos is just tremendous and really makes this program great.
So for documentation purposes, we provide a written chart, and photo documentation, and that chart is sent to medical records for inclusion in the electronic health record. The exam photos are physically transported to the CAC with the chain of custody documentation for processing and secure storage. And then our plan, and it's already in the works, Cherith has already worked with our EPIC team at the hospital to transition our pediatric SANE charting into the electronic health record. So all of this will become digital, and it will make it much easier, including photo storage, and that is going to make it much easier and more efficient and all the way around. And here's our written documentation. And it's a pretty lengthy form, 17 pages, I think, that we've modified many times and added and taken away, but it's really just a checkbox form with blanks, that are prompts to fill in, questions to ask, history questions, great diagrams for nurses to document injuries. We have place where we document verbatim statements from the child, unsanitized statements. We have the injury log, which is important, where we can catalog all injuries that are documented, and then the pain scale, which is important for if there's litigation of a case, because the child's subjective experience of pain due to potential inflicted injury is, I guess, is an important component in the court process. So we have a place where we document, where we ask children, you know, on a scale of 1 to 10, you know, is that painful? How painful is that? And so on. So for documentation, the National Children Alliance states that diagnostic quality photographic documentation of the anal genital exam findings should be obtained in all cases of suspected sexual abuse using still and or photo documentation. So there are various forms, there are various tools that can be used. A standard point and shoot, high quality camera or DSLR camera or a colposcope can be used. But we document, even in normal examinations, we document, we do photo documentation of the anal genital exam in every case. And we get parents' consent in order to do that as well. So Children's Advocacy Center and Pediatric SANE providers in this program align basically so that kids can access the 24/7 specialized evaluation that they're entitled to. And by doing this, we've standardized care for the acute child sexual abuse examination. And I think in the process have improved the quality of the care that is delivered. So continuous quality improvement is the process-based, data-driven approach to improving the quality of a product or service. And it operates under the belief that there is always room for improving operations, processes, and activities to increase quality. And so the quality measures that we have in place are, one, our medical coordinator at the Children's Advocacy Center contacts the family, the patient and the family that was seen in the emergency department within 48 hours of the hospital visit to provide advocacy, to arrange follow-up examinations, to check in, to answer questions. But that contact is very, very important. And that ensures that the family has somebody that they can call when they have questions about something that might be happening. At that point, we may, you know, at the parent or family's request, we may loop the primary care provider in if there are ongoing medical needs at that point, but it's really a care coordination attempt and a standard that we have in place with this child at the center. And we also are implementing suicidality screening and documentation of adverse childhood experience scores as part of the emergency room evaluation. We do chart audits on every chart actually that we see, every patient that we see. And we do annual meetings with the emergency department medical directors to assess the program and target areas to improve. And this is all written in to the quality measures in the agreements that we have with both hospitals. We agree to do these things and report back to the hospital. And just another word on court. So this can be a big stressor for anyone really, but especially if you don't spend a lot of time in the courtroom, which most medical providers don't. So one of the really great things about the Pediatric SANE program and having kind of the tie in and being an arm of the Children's Advocacy Center is that we have direct communication with the DA's office who sets the trial dates and times. We have just an easy way of getting hold of one another and understanding as the trial date approaches, getting time scheduled to have a meeting to make sure everybody has the information and has a clear understanding of the medical information. And that goes for defense as well. But the CAC model really facilitates that communication. In addition to that, we do trial preparation. So all of our nurses will prep for their trial with the medical director just to review the case, review the documentation. And then our nurses, they testify as fact witnesses. Challenges of the program. So when we kind of, and we think about these things a lot as we're trying to learn ways to become more efficient, to improve. One thing, and there's just no getting around it, is there's a low exam volume. So you have to overcome that with really creative ways because of training and maintaining competency. So the simulation lab is one way. Every time we have a quarterly peer review, we do a mock exam or talk through examinations, we practice with the camera, and you have to commit to doing these things so that when you're the one called to walk in to see the child in the emergency department, there's no questions as to your ability to do so. There's no anxiety around that. You're just ready to go. And complexity of scheduling can be a problem as well, because you have nurses that are doing this as a second job, and often they're working nights, working on the weekends, working odd shifts in the emergency department. So we have to set our schedule out in almost a year in advance so that people can adjust their primary work schedules to accommodate the meetings that we require them to attend. Funding, of course, is always a challenge, and we're always going to be worried about that and thinking about that and making sure that that remains stable to continue the support of our program. Exam logistics in the emergency department. When a second nurse can't respond, there's just no one available. We've gotten around that by utilizing emergency department techs or other nurses, but there is often a need for a second set of hands when you're talking about photographing children who don't sit still. You need helpers sometimes. So in a busy emergency department, that can be hard. And then another thing is just the referral process and getting all the information kind of packaged up to the Children's Advocacy Center, so all that great 48-hour follow-up and contact can be done. And we're trying to automate that through the EPIC process and through direct communication, but that can be a barrier too. So just to summarize the program, I think the key components have been the medical director and program coordinator working really closely together. There are a lot of logistics in managing a program like this, from the small things to the big things, and it's usually all the small things that matter the most. The stocking the carts, the sending the emails, to taking attendance, making sure people are, adhering to their quality measures with their 6 months between exams and getting training, making sure we have all the proper protocols in place and everything's up to date. So I think having somebody who has, or a couple of people who take responsibility for the program's success, and I think that's true for many things, but it's definitely been true for this. Secondly, the CAC director, CAC executive director and board of directors support, just critical. And that partnership has been really, the foundation of why this program was allowed to happen, and then us being able to get that support from the hospital. So that's just been critical. And then relationships. So having relationships with people in the emergency department, in the lab, when you're discussing lab protocols and how, testing for STDs in children is a little bit different in terms of the tests that we use and the confirmatory tests that need to be done. So having a contact and somebody that you can call and ask questions about for, what you might be needing. So the lab is one example, but also medical records in the hospital, having somebody there that you can discuss how to get the chart securely transferred into the EHR, and the billing department just the same. So there's just a lot of little pieces that have to work together, and I think it really depends on how good your relationships are with people, because once you talk about child sexual abuse and what we're doing and what our goal is, people are on board. But I think it's the making the connection and establishing the relationships that really helps. But of course, the hospital administration relationships, very, very important, and relationships sort of on the team and kind of promoting the team atmosphere, because this is something that nurses have to want to do. They have to be motivated. They have to be self-directed learners. They have to be passionate about child abuse, because this is not for everybody. So finding the right people to facilitate a really high functioning team, I think really is important as well. The endorsement of the task force, I think has been also really critical. And then the quality improvement and peer review that we require. That keeps everybody accountable, that keeps everybody doing their best work. And I think that, you know, that is really also one of the strong foundations of this program and the thing that helps to make it successful. So with that, I think we're going to conclude, and I really thank you all for your time and learning about our program and a little bit about the CAC model and child sexual abuse. And I hope you have a great rest of the conference. Please feel free to contact myself or Cherith if you have any questions or feedback. We'd be happy to hear from you. So get in touch if that would be helpful. Thank you.